Very much appreciate. Dr. David Sinimo is a graduate of where? Rutgers Medical School. There we go, theme of the day. Where he also completed a combined internal medicine pediatrics residency, internal medicine chief residency, and fellowships in both adult and pediatric infectious diseases. He is currently he currently practices clinical infectious diseases and infection control with see, why don't I wear my glasses, friends? Forgive me. With clinical focus, with a clinical focus on HIV, tuberculosis, and emerging pathogens to vaccine implementation, and infection prevention. I apologize. This is why I need my glasses all the time. He continues to pursue his passion for medical education as core faculty in multiple residency and fellowship programs, and he is also an associate professor and associate dean for education at the New Jersey Medical School. And again, I just want to remind you that the full bios are available on our website. That QR code is on the inside of your program, and there's more to Dr. Sinimo's background. In particular, the Veterans Affairs work, right, which I didn't even mention here. So I encourage you to be sure to check out the full bios as well. Thank you so much for joining us, Dr. Sinimo. You can just click the clicker, and the green goes forward, red goes back if you need.
Great.
Thank you so much.
All right, thank you so much for that. I should have sent you the shorter introduction, I'm sorry. So yeah, you didn't hear the VA part because I'm on vacation today. And I think everybody sort of realizes why I don't want to be a federal employee at this moment. Still trying to survive the rift, though, because I need the paycheck, even if I don't agree with everything. So that's one thing I'm disclosing. And I am here actually as a Rutgers faculty member. The thing I truly have to disclose is I have no idea what I'm doing. Because I was asked to talk about, where's ACIP going? Gone was not actually the thought when I, so sorry. But I will tell you, I actually was not in a really good spot putting this together, mentally spot. It feels like it was 6 months ago. I think I sent you the slides, 5 days ago? But I thought, you know what, let's talk about recent history and maybe talk about the good things we did. And we can keep doing, and I'm going to weave that in a little bit, but I have no idea what the vaccine recommendations are going to be. So let's pretend we do. I'm really happy that I downloaded the picture. That's the one that you're getting outside. Yay. You all know this, right? I don't have to show this to you. I don't have to teach this to you. I do, and by the way, no yellow on this one. I didn't realize that, but no yellow. So, I get it. This is confusing. This is overwhelming. This seems like a lot, right? If you're a parent or if you're a patient. The thing that I wasn't planning to point out is if you look at the bottom right of this, I guess your left, I don't know how long that's going to stay there, right? And those are the endorsements by the professional societies. Wasn't absolutely not planning to say this, but I spent most of lunch, I think you call it doom scrolling. I think that's what my students call it. I don't really know what that means. But obsessively reading all of my news posts and everything else. And the thing that I'm happy about is the professional societies to which I belong. American Academy of Pediatrics, Infectious Disease Society of America, American College of Physicians, so that's internal medicine, are coming out and saying, hey, pump the brakes. We're really worried about what's going on. And that's, I believe, our responsibility. I think that's going to be the responsibility for pretty much all of us in this room. And then the other thing, when I was talking out there, and we made a joke, well, we spent all this money publishing these things, printing them, probably get thrown out now, right? And then I thought, yeah, I guess they are. But then maybe not. Maybe they're actually a collector's item. I know, right? But you know what? Then I thought more about it. And I think that even if they are a collector's item, I think they're very valuable because they're true, okay? Thank you. So I answered a lot of texts on the drive down here and reminded myself why I'm a Newark Rutgers guy and not a New Brunswick Rutgers guy after sitting on Route 18 for a while. But you know, friends, family texting me like, what's going on? And you know, and I keep texting them back. A lot is changing except the science, right? So that which we believed to be the best recommendations yesterday are still them. I haven't seen anything that says that COVID vaccine is dangerous in pregnancy. No, I have reams of data that we're not going to actually talk about that says it's actually safe, incredibly beneficial. So this is my plan to sort of hold the line until we get more data. And admittedly, I may be wrong. Something I may be telling you right now, 5 years from now, could turn out to be incorrect when we learn more. But as of now, not so much, and this is what is true. So here's what I think is confusing. I think the most confusing thing that we're seeing is what are we doing with respiratory viruses, okay? And you'll see that the 2024 to 2025 recommendations changed a bunch. Just out of curiosity, who here, because this is a very polarizing comment, who here hates the term shared clinical decision making? Okay. People either love it or hate it. It's funny, you're a very vaccine-centric audience, so you don't care that much about it. You're like, I could deal with that. When I talk to medical residents, students, they hate it, right? Because they're like, no, yes or no, right? What is the single best answer? I want single best answer. And so we're unfortunately, admittedly, seeing more questions because of this idea of shared clinical decision making. But again, you know what is true. So influenza, we will have influenza vaccines next year. These are our components. I don't know, if you're a really flu geek, you really like this stuff. Why did I look this up specifically? Because a lot of people are concerned that we're no longer participating in WHO, right? And WHO is the group that puts together the recommendations nationally. So yes, we're no longer playing in that sandbox. Surprisingly, these are the exact recommendations that the US independently came up with, wink, 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 and they match exactly what the WHO suggested, the Europeans suggested, right? So no fleeing to Canada for the better flu shot. What do we know really, again, strongly? If you are older, a high dose or an adjuvanted flu vaccine is better for you, right? And if you're reading older recommendations, you remember older stuff, we were like, well, you know, if you can, you know, it might be better. No, strong recommendation, it's better. Now, what's the caveat of that strong recommendation? If you don't have that available, some flu vaccine is better than no flu vaccine. But, you know, for instance, and I can disclose this from working from the VA, we preferentially were buying, because many of our patients are older, the higher dose vaccine and putting that in the clinics, really pushing that as our #1 choice. I think really the amazing, you know, change has been RSV. And although I work in the Department of Veterans Affairs now, I'm still a med-peds resident deep down inside. I still hear the NICU phone ringing sometimes in some of my nightmares. And so what we've done for RSV in infants, but also in adults, really should be celebrated. And so I think that we're not using enough nirserumab. I think it's hard to find, it's hard to get. I've been talking with my colleagues. A lot of the hospitals aren't stocking it. But we know that this is a really important thing, right? I don't understand why we're not doing more maternal RSV vaccine. And thank you, I see some people nodding. It is pretty clear. Now, is it a little more difficult? Yes, why? Because we have multiple products, but only one is actually approved in pregnancy, right? And so this is not me trying to advertise for one product. This is the only one out of the 3 that's approved in pregnancy. I don't understand, and you'll see this when I really focus on pneumococcal vaccine. I don't understand why this isn't standard, why we're not saying every pregnancy should be offered this. Now, it does get a little confusing. It gets a little confusing because it's right now only a one-time dose, right? So it's not actually every pregnancy for subsequent pregnancies. That's something in my, off-label I keep an eye on. We'll see. I don't know. But to prevent those infants, those newborns coming back in with RSV, this has been invaluable. Also, very strong data, RSV is bad in adults, especially in high-risk adults, adults that are older age, that have various comorbidities. And, whenever we talk about high risk, and we're gonna, I guess, see that probably coming out with COVID, this is a lot of Americans, right? So, we think about high risk as a few percentage points. That's not the case. This is many, many people. And so because of that, we have significant burden of RSV disease, right? 100,000 hospitalizations a year from RSV is nothing to laugh at. It's nothing to ignore. And you could prevent it, or at least ameliorate it, with vaccination. So right now we have 3 RSV vaccines available for older adults. Data are still being accrued, right? We have good 1-year data for effectiveness, and I would take anything that's gonna protect me 75% of the time, right? This is a peeve of mine. This is something that the vaccine, I'm not even gonna dignify it by saying vaccine hesitant. The anti-vaccine groups will say, well, it's not 100%. Okay. I mean, I made, how many jokes am I gonna make today about driving here? Nothing is 100%. I think my side curtain airbags work. I think my front airbag will work. I think that my seatbelt will work. And I hope that all of them together will never actually have to be used. But if they are used, I hope they work. But I don't 100% know that, but I still made sure they were put in the car, right? So yeah, this vaccine is not 100%, nothing is 100%. 77% is still pretty good. The question to me is, how long will this effectiveness last? If you look at the company's data, they have data for antibody levels, and they do wane over time. They're accruing data now that should actually be published really soon, up to 2 years. I have a gut feeling. Again, whenever I say gut feeling, this is not published. I've asked the reps of all of these companies about my gut feeling, and they just stare at me and say, we can't talk about that. But my gut feeling is you'll get boosters on this, that the effectiveness will wane over time. Over how many years, I don't know. But I don't think it's looking like it's something that's going to be lifetime effective. And that's something that we'll have to think about, as we do more and more of this vaccination. So right now, this has been a moving target. We have a strong recommendation for age over 75. Age 60 to 74 recommended with a concomitant risk factor. Let's face it, pretty much everybody can get a concomitant risk factor out of this. And right now, we don't know anything about subsequent doses. I get a bunch of questions about co-administration with other vaccines. No safety concerns and no efficacy concerns. The thing that I was really looking forward was more data on higher risk groups at younger age. So in June 7th, 2024, which sounds like it was a decade ago, or feels like it was a decade ago, the FDA did approve the GSK vaccine for high-risk patients 50 to 59 years old. I really thought we were going to get an ACIP recommendation out of that. We didn't. Clearly, I don't think anything is going to be forthcoming now. So I don't know, and we can't talk about this, but logic to me dictates that in specifically immunocompromised hosts, transplant patients, cancer patients, maybe severe lung disease, it could have a benefit, but I don't know, right? And we don't have a recommendation to speak on that, and we don't really have robust studies that have published yet. Some are being done in those risk groups. Yeah, I don't know. I don't know. So I was really hopeful when the Moderna's updated vaccine got FDA approval. And I was like, oh, wait, so maybe the things are going to still work. But then there's this question of really the companies being put in this catch-22 of we recommend that you update the vaccine, but also if you update the vaccine, we're going to tell you you need to do these multi-year placebo-controlled studies. And forgetting anything about a business model, because I never did a business class in my life, it's literally unethical to do a placebo-controlled COVID vaccine trial because we have reams of data that COVID vaccines are safe and effective. And so to give somebody a placebo is not actually ethical. So I do think we will have COVID vaccines. I do think the people that want them will get them. And I say that with the huge shaker of salt over here that has to admit that our COVID updated vaccines, because I hesitate to say booster because just I'm a little pedantic like that, we haven't done a great job. I mean, we're at like, what, 20% of the population is getting a COVID vaccine anyway? So I'm not sure that this is going to be as much of an uptake issue as it is a PR nightmare. And the reason I consider it a PR nightmare is because I have people in my literal family who are saying, you see, those vaccines never were tested. That's why they had to pull them. And I kind of want to beat my head against a brick wall. But that is the message that's getting through, and I'm sorry, that's what we're all going to deal with this upcoming vaccine season. So Ray, yay, now I'm extra depressed. And I did make a promise that I would not use any profanity. Still working on that. But you know what? I think pneumococcal vaccine is incredibly confusing, but a true success story of what's been happening. So that's why I want to focus on that a little bit, because it makes me feel good. So the history of pneumococcal vaccine was there was the polysaccharide vaccine, PPSV23, right? And that was for people over 65, and that started in the 80s. And it did really well. But the really well was it was preventing invasive pneumococcal disease in some number of patients. Then we got PCV7, the conjugated vaccine. And remember, we gave conjugated vaccine because infant immune systems don't really recognize polysaccharide vaccines well. And so we started that off, and you know what? Let me go to the next one. And what we saw was children stopped getting invasive pneumococcal disease at significant levels. That was great, right? So the sort of allegory I always say is I graduated medical school in 2001. By the way, thank you for the intro, because I still forget I'm a Rutgers alum, because it was UMD&J back then. So thanks. I'll donate now. And so, we saw a ton of pneumococcal disease in infants and children. I've never seen, pretend that's wood, I've never seen Hib meningitis. Pretty sure I'm going to, but I never have. My mentors, that was a monthly admission to the hospital, right? But Hib vaccine works. Pneumococcal vaccine worked for children, and my students and residents have never seen invasive pneumococcal disease, right? They're like, wait, why do you have to give all this ceftriaxone? You know, that's not a big deal, it's probably a virus. The thing that this graph is showing you is it also dropped the incidence of pneumococcal disease in adults, right? So then the talking point was you're immunizing the kid to protect the kid, but also grandma, right? Because, you know, it's one thing we learn in pediatrics, kids are little bags of germs and they spread them all over the place. So how about we give that vaccine then to grandma and grandpa? And it helped, but honestly, not nearly as much as immunizing the kids. And so that's how you got those confusing, what feels like confusing, flip-flopping recommendations of give the vaccine to adults. Well, shared clinical decision-making with the adults, because immunizing the kids helped more. But certainly we know that targeting this vaccine in the adult population also helped. But we're honestly not that great at it, right? So this is, how big is it projecting? Okay, good. So the top line is pneumococcal vaccine coverage, age over 65. The bottom line, the 33%, is pneumococcal vaccine coverage in high-risk patients. And remember these. So this graph always sparks anger in me too, because I think it's inexcusable that high-risk adults with a strong vaccine recommendation, only a third of them are vaccinated. And the reason I say that is, almost by definition, you see medical care. You have doctors, right? If you're high risk, you're not in the community, I hope, and granted, there are some people that do have limited care, but I always show this graph and I ask, hey, did your cardiologist ask you if you have pneumococcal vaccine? Did your nephrologist? Did your oncologist? Right, because it can't just be ID. It can't even just be primary care because we're missing people. So when you look at those data, and then you look at those data broken down, I mean, if anybody is actually surprised, I mean, you might be surprised that in today's day and age, I actually can show this. Again, I'm on vacation from the VA, so I'm allowed to say the word disparity. But it's funny enough, I'm pretty sure some people from the VA are logged in the Zoom, so like literally I took AL today, don't call anybody. But even as bad as we're worse in our groups that we would all know are our highest risk, right? Because we're, again, bad at care. And here's the funny thing, we're much better at blanket recommendations than we are at nuance. So the minute you start saying, consider this, nuance that, shared clinical decision-making, you know your numbers are gonna go down. And that is actually why this vaccine got dropped to 50, right? Because that weirded a lot of people out, like 50. 50 is not a number we're used to seeing, right? 50 is like, well, it's kind of like shingles vaccine, but 65 was the magic number for all of this stuff. So they dropped the age because when you really look at these data, adults 50 to 64 with invasive pneumococcal disease, 90% of them had a high-risk infection, a high-risk condition. They had a comorbidity that they should have gotten this vaccine, but they didn't, right? For whatever reason, our recommendations, education, whatever had failed, and they weren't given this vaccine, they got sick. And disproportionately, those were people of color. And so how can you fix that? You give up. And in my world, giving up is, okay, just give it to everybody at age 50. And then we'll get the group that actually really needs it, okay? And so I think, and I love this story, and I'm absolutely, glossing over a lot of the making of the sausage here, but I love this story because this is true public health. This is letting the data tell you how to drive a policy. So we did have disparities. And so, unfortunately, we don't have data to say that right now this change in recommendations has fixed it. But I don't think it could have hurt. The other thing that happened to make this more confusing is, we had 7, then we had 13, then we had 15 and 20 came out together, and it was give 20 or give 15 plus 23. And if you could imagine trying to explain this and operationalize this in your clinic, right? This was a lot of pages or text to me, like which one should we get? And then, hey, 2024, here's 21. And so, wait, so is 20 or 21 better? What is that about? And so you see the recommendations for 21. 21 is not FDA approved yet in children. So that is a confusing. 20 is, 21 is not. But 21 is not 20 plus 1. Okay? Because frankly, they're different companies, right? So they have different proprietary components. So by going from 20 to 21, you actually got 8 new serotypes and lost 10. And I have a graphic that'll show you that in a second. So right now, the take-home point is you can give 20 or 21, and I can't tell you which is better, okay? I can tell you already know who has increased risk, and I could tell you that none of these is going to be 100%, because there's a lot of pneumococcus out there, and there's more than 20, and there's more than 21. So something's going to get through the force field, even if these were 100% effective. And so 80%, or to say it another way, 20% of invasive pneumococcal disease across the country would not be covered by 21, okay? And that's just the way that it is. And 20 isn't gonna be any better. So looking at this sort of graphic, these are the serotypes. And if you're like really into this, you'll obsess over what's the serotype. I have to tell you, if there's anybody in here from the state, I'm sure there's a ton of people in there, I can't get pneumococcus serotyped anywhere. So even when I have a patient with a positive blood culture, LabCorp won't do it, Quest won't do it. So I have no idea what is actually happening. But if you're asked a question about this, the big deal is serotype 4. So serotype 4 was very prevalent in the Wayback Machine. Kids would get it a lot. But it was covered, you see, by the PCV7, actually. And so we got it out of the population pretty quickly. Unfortunately, it's sort of making a comeback. And it's making a comeback in very high-risk adults. And not only, high risk by age, but comorbidities like alcohol use, injection drug use, homelessness, and keep in your head Native Americans, because the next slide is going to really matter about that. And the key, if you care about this, is that it is not included in PCV21. It is included in PCV20. So we could wind up in a situation where one might be preferred over the other. I don't know that, right? And we have no data for New Jersey on that now. But if you were to live in Alaska, where the significant yearly burden of invasive pneumococcal disease is in the indigenous population, and you were to have serotype data, because you do it in Alaska, you know that they're all getting serotype 4. So actually, they came out and said, do not use PCV21. Again, that's Alaska. We're not in Alaska. We're in New Jersey, and I don't know, because the state of New Jersey does not track the serotype data. So now we wind up with things like this, which is literally what I have in our clinics. And I think it's getting easier again, because we're basically just back to a give them one, right? PCV20 or PCV21, give them one and they're fine. there are ways, we're getting out of the population that's catching up, okay? But if we are dropping this down to 50, does it really last, right? Because it was once for the lifetime after age 65. Does that mean it's still once for the lifetime after age 50? I don't know, right? And I have to, and I agree with some of the presenters that I've already heard this morning, we need to get better at I don't know, okay? Because that's truth. I don't know if a thing that has only been out a year lasts 15 years or 20 years. And if I told you that I knew, I would be lying because it's not 15 years from now, right? I don't know. There's a lot of things in medicine we don't know. It makes people really uncomfortable when they hear us say that, but that's the truth. So as we dropped the age for this, and this is a direct cut from the MMWR article, we had to admit we may need to dose this again. I don't know. And it may be at age 50 and at age 65. We have to watch the data. The data will be infection data, true correlates of protection, and it will be, true protection and correlates of protection. What do the antibodies look like? Who knows? So I won't belabor that point because that's why we are going to have this conference every year. Ugh. So I've actually seen measles. That's why I wound up talking about measles. There's anybody who's been around long enough. There was an exposure at University Hospital where there was like over 500 people exposed. That was me, my patient, just so you know. Furloughed, we had to furlough the entire transplant team because they were not known to be immune. And it was a patient came into our clinic and was recognized very quickly to have had measles, thank you. But unfortunately, we learned after the fact of them waiting in the waiting room for some number of minutes that the entire building's air supply was shared. And I know that there are people in the audience that were present for this story. And the building was not only the infectious diseases clinic, it was OBGYN, liver transplant, orthopedics. And so we also at that point learned that we had not updated our employee health guidance, and we were still using presumptive immunity for physicians. And so we had a whole bunch of older physicians, one of whom being my mentor, who I was like, boss, can you come over here? Because I think this is measles, but I've never seen it. Pretty sure it's measles. And he walked in the room, said, yep, that's measles, turned around and walked out and said, good luck. So here we go again. We're not Texas yet, yay. But just to remind everyone that as of today, this is how you are considered immune. I don't think we have a lot of people who were vaccinated between 63 and 67 with a presumptively ineffective or less effective measles vaccine, but that is something to keep in mind. But this isn't really the questions that we're getting. So I get from local pediatricians, should we be vaccinating infants before the 12 to 15 month recommendation? And as of now, in this state, the answer is no. But it's not a crazy question, right? Because we know from travel recommendations that if we're sending an infant into a country, or a state at this point. See, even I still have to remember that they have an appreciable risk of contracting measles. We can vaccinate at 6 months old. We cannot count that vaccine, right? Like that's a 0. That's not a number 1. That's a 0. But we can. We also know that if we're going into a high-risk vaccine or a high-risk infection area, while we talk about 12 to 15 months, 4 to 6 years, you really only must have 4 weeks in between. And so you can give dose 1, dose 2, separated by a month to maximize your acquisition of immunity. And again, right now, no, not needed, but something to keep in the back of your mind. In Texas, in West Texas specifically, they did change the recommendation. And they did say we have so much measles right now. And measles, remember, a ridiculously contagious disease or infection. You know, R0's 15, 18. I mean, it's the most contagious thing we have. And they said, you know, just start immunizing. And the problem is, you already have such low vaccine uptake there. It wasn't a lack of vaccine that was doing it. Why not everybody? So this is what you're going to get quoted. This is a very small, very, very small Dutch study. But it looked at, there was an outbreak in the Netherlands, and it looked at giving early vaccine, infant vaccine. And in some of the patients, I really question this because the N was only 44, but they had lower overall antibody levels. So there is a theoretical, and I say theoretical because I don't know that these are totally the most robust data, theoretical risk that giving the vaccine early can compromise the total longevity of the vaccine and the total effectiveness. But we don't really know that, and it's going to be a risk-benefit. And this is where we really need, good, robust public health communication if we ever have to turn that switch. So it is not currently recommended in New Jersey, but should it be, this is the most high-risk schedule. And you're really trying to get immediate immunity for children who are most at risk because you have a lot of ongoing transmission. So I think, again, I think I was less negative than I was worried about being, honestly. We know, everybody in this room knows this stuff all works. Everybody in this room knows this stuff is overwhelmingly safe. It's not 100% safe. I will never say it's 100% safe. Everybody knows that it is very highly favorable in the risk-benefit ratio. I think we can all communicate it. I don't know what's going to happen, but I know that if we stop being able to communicate it, what's going to happen is bad. And so, thank you. I'm happy. Do we have time for questions? Yeah. So I was hoping to get through this so we can ask more specific questions. And just thank you for being here and being the people that want to fight this fight in a time where it's really going to hurt.
Thank you so much.
Thank you.
Thank you. If you can raise your hand if you have a question for Dr. Sanimo. Any questions at all? That's shocking.
Can I ask?
Oh,
can I
we do?
ask the audience a question while you're thinking of that, or while you're getting the mic back
Go ahead,
there?
sure.
How many people are checking titers on your patients for measles titers? It's only a couple hands went up if anybody's looking.
I was just wondering about the protection for an infant that's breastfed with measles.
Yeah. So that's a great question. So there's probably very little. Okay. So this is one of the dirty secrets that I talk about actually with my students, and I always tell them don't talk about this stuff in a room full of people because it's going to be misconstrued. So the anti-vaccine people are right about some things. And one of the things that they are right about is infection-derived immunity in most cases, and for measles definitely, has higher levels of immunity, higher antibody levels than vaccine-derived immunity. Caveat number one, I try very hard not to say natural immunity, because there's this whole idea that natural is better. In this case, natural is not better. You're going to get infected with a virus that has a 1 in 1,000 chance of killing you. That's not better. But the majority of moms right now have been immunized with MMR. They're immune from immunization. They actually have fairly low levels of circulating antibody. They're enough to prevent symptomatic infection if they're exposed, but there's not a lot of antibody that's getting crossed in the placenta, and there's not a lot of antibody that is getting manufactured in real time that's going to get into breast milk. So it's really not a great protection. And you know this from the maternal vaccine literature of this is why we've got to give you that Tdap every time you're pregnant, because we got to get those antibodies up higher. Now, in magic theory land, which is where I like to hang out a lot of times, those pregnant women in West Texas are probably getting a booster. It's called the virus being inhaled, have probably made some amount of antibodies, so they may have some correlate of protection going across the placenta, but we really can't depend on it in any way to protect a newborn now.
Hi, I just wanted to, for you to clarify, you said the earliest, so normally they would get it, say, at 12 months. Mm-hmm. But you're saying the earliest they could get it would be at 6 months, would be the earliest?
So,
or
yeah,
they could get it before 6 months, and then the second dose could be given at 7 months?
no, okay, that's a great question. So the earliest that we have data to give this vaccine, the safety data goes down to 6 months. So it's a big unknown between birth and 6 months. And no one that I'm aware of is giving MMR vaccine less than 6 months old. If you give it at 6 months old, you would still wait for 12 months old to give dose number 2. But like, let's say you've got a 3-year-old and the parents are like, wait a minute, I was never in favor of vaccines, but hey, this stuff is real now, right? Because I was going to ride the herd immunity, but now I hear that we don't have herd immunity. And there's kids at school that are now coming down with symptoms that are measles. You can give a dose now and a dose in 28 days to make up, to give them both shots. But 6 months old is, again, that's why they label it as dose 0. It wouldn't go on the vaccine card anywhere. It doesn't count.
Thank you. Do you have a question over there, Jen? Anyone else? Anyone else? Nothing on Zoom, I don't think? Nope.
No? All right. Well, thank you all so much. Have a great day.
Don't be getting too far away. We can exit out of this one. Thank you. And that one will just minimize. Yes, this one can be deleted. His is good. Oh, that's okay. So we are, Thank you. Kendra, we're good to continue? Okay. Thank you again, Dr. Sinimo. That was excellent. Excellent. Thank you. Yeah, we can do that. We can do another. We can do that for sure. Okay, we are moving on to our final session for today. Thank you all for joining us and sticking with us. We're really appreciative of your participation, including those of you on Zoom. Our final presenter is Jay Middleton, who does his best not to let his run-in with cancer define his life. Instead, he does his best to lean in to letting cancer, his love for cycling and the outdoors, and his passion to make a difference inform how he moves through the second half of his life. As an avid cyclist before cancer, Jay continued to ride throughout his cancer treatments during the pandemic, and now uses his bike adventures, and sometimes misadventures, as a vehicle for fundraising and advocacy work. He credits his brush with cancer for strengthening his marriage, deepening his friendship, and providing the catalyst to leaving the private sector to pursue a career in the nonprofit space with Habitat for Humanity. And I just want to say for one moment, as Mr. Middleton, you can come on up. I think you all know as public health, yes, we can do that. You know, one of the things we say more often than not in the world of communicating public health messages, right, is we can give all the data we want, we can give all of the information and the technical knowledge we want, but it is the human stories and the true stories that really make the most impact for people. So we're really appreciative of you being here. So come on up, and I will give you this. We can advance it that way.
All right.
If you mess up and you want to go back, you can do that.
Okay.
You good to go?
I need that back button because I will mess up.
Well, we always do.
Yeah.
That's okay. And here you go.
All right. So I've done this before, actually a lot, actually, over the last 5 years. And I'm really nervous for this one because no one's ever phoned me halfway across the country to speak at a university. So thank you all for having me here. A couple things that we're going to talk about today and some questions that have probably jumped into your mind right away when you saw this first slide, and we will get to this, is why is there a 56-year-old man standing up here in front of a unicorn riding a bicycle? I also am going to take some time today and share a little bit about my journey the last 5 years. My cancer started or was diagnosed and treated during the pandemic. And also I want to hopefully give a little bit of context and hope for I'll just say it, the battle that we're fighting with people who are resistant to getting vaccinated, for not just for HPV like I had, but for pretty much anything that a vaccine can help reduce our risk. So let's get started. And green button, right? Maybe I can just try, let me try the space bar here. No worries. I'm gonna wait till you get up here, then I'll push the button and it'll work. Nope.
You're looking to move it? Can you try aiming up there, maybe? Like over here.
Hey, how'd you do that?
Oh, you might have to hit the keys on the side.
Okay, I can do that.
You would?
Yeah. This probably has music to it. Can we turn the volume down on the computer?
Yeah.
Okay, great, thank you. We're gonna get to that joke in a second also. Let's hope this works. Nope. There's supposed to be a video embedded. Excellent. There's supposed to be a video embedded in this. Yeah, that's me.
the app installed.
Okay. You know what? We're just going to roll with this.
Okay.
Okay.
Yeah.
I'm going to paint a picture for you. When I hit the green button on this video starts playing, and this video is literally just a montage of me doing really cool stuff in Colorado, because that's where I'm from. It's where I live. The southern accent comes from Georgia. And there's videos of me right after surgery. There's videos or pictures of me with my face all sort of gross looking from radiation. Are you getting the picture? Okay, great. Y'all probably seen it all before. You're like, that's nothing. We see that every day. And as that video is playing behind me, I'm going to say the following. Good morning. Wrote this at the wrong time of day. Good afternoon. I'm sure as you view the montage playing behind me, you're imagining that, right? You're saying to yourself, that guy up there is so amazing. Head and neck cancer survivor. Nothing seems to be slowing him down. And he has it all figured out. Did y'all think that? Yes. Well, first of all, thank you if you did think that, but you'd only be partially correct. I do feel that I managed the news of my head and neck cancer diagnosis as well as anybody. I seized the opportunity to make the best of what was a pretty crummy time in my life. As I moved through surgery, recovery, radiation, and then more recovery, my treatment during the pandemic was all about taking care of myself and time with friends and family. Of course, this was during the pandemic, so we did it all at a safe distance. It also proved to be the perfect time for plenty of bike rides, hiking, camping, and exploring Colorado with my wife. That's the easy, fun part to talk about. The side that I've been reluctant to share are the mental struggles that have slowly crept into my life in the last couple of years. Sorry, this is still hard for me to talk about. As I've closed in on what feels like a very arbitrary date of being 5 years with no evidence disease, I have struggled. This year, I have finally had to admit to myself that maybe the typical man way of dealing with the stuff in my head by pushing it deep down inside into my stomach and a little black ball was not the healthiest way to approach my own mental health. I've tried really hard these last 5 years not to let cancer define me, but I'm not sure that it's always the case. I used to tell people that head and neck cancer likes to leave you with reminders that it was here. For me, those reminders are salivary glands that don't work like they used to. It's very hard for me to eat a peanut butter and jelly sandwich without at least one large glass of water to chase it down. I also have a $20 a month habit of high fluoride prescription toothpaste. I have scar tissue in my neck that limits my mobility, and I have a super fancy compression garment and pump to ward off lymphedema that I have a date with several times a week. And of course, this interesting mental health struggle going on in my head. Don't worry, I'm not going to unpack all of this baggage on you today. I have a well-paid and wonderful therapist for that. So how did I get here? In 2019, I was 50 years old and really having what I thought was one of the best years of my life. I was on a 20-year sabbatical. I used to work for the outdoor company REI, if you're familiar with them. Wonderful company that was incredibly supportive during my time with cancer. They are also incredible in the sense that I got at 15 and 20 and so on years a sabbatical. My wife and I spent a good portion of that in the fall of 2019 riding our bikes around Italy. When I got home, I picked up a really bad sinus infection. Not unusual. I've struggled with sinus infections and asthma all my life. What was really unusual is this large knot had returned to the side of my neck. Now, this had happened once before, earlier in 2019. And my doctor and I contributed it probably just to, once again, a bad sinus infection. Antibiotics seemed to clear it up. And for the most part, the lump went away. If I pressed deeply into the skin, I could still feel maybe what I thought was just a little hard tissue back there. Doctor prescribed a course of antibiotics. The sinus infection went away, but the lump did not. So I did what any normal person would do. No, I didn't go to WebMD. I went to my administrative assistant because she's a mother of two. And everybody knows that mothers know the most about medicine and how to take care of yourself. And I remember this day in the office, I said, hey, Kristen, I've got this lump on my neck and it won't go away. I was like, what do you think it is? And she put her, mom hands up there and she touched it gently. She's like, didn't say anything and her eyes got really big. And I said, what? And she said, I don't know, but you need to go to the doctor. So I followed her advice and went back to my doctor. And he too, along with Kristen, was a little bit concerned about this lump that would not go away. So that led to an MRI, which led to a needle biopsy, which led to an ultrasound biopsy, which eventually led to me getting a PET scan. And then that led to the dreaded phone call. Now, I have a theory, and I don't know if it's correct. Maybe theory is not even the right word, but I've talked to numerous people who've been diagnosed with cancer or some other serious illness, and long before you get that physical or that official diagnosis, you kind of know in the back of your head and in the pit of your stomach that the doctor's going to say, you've got cancer. And that's what my doctor did. He called me at work. I took the call. He gave me the diagnosis, which in terms of diagnosis, he seemed pretty optimistic that it was very treatable, and obviously it was. And I thanked him and continued on with my day. And then I went home and did one of the hardest things I've ever had to do in my life, and that was to tell my wife. Way easier was the treatments, the radiation, than having to tell my wife. After we got the tears out of the way, I thought it would be a good idea to name the foe. And if you're a cyclist, or maybe you remember, I don't know, 10, 15, 20 years ago, there was this American who kept winning a race in France. And then it turned out that maybe he wasn't winning them fairly. I'm a huge cyclist, so I had to pay tribute to the man, Lance Armstrong, and I named my lump after him. And I thought it was pretty funny. Most of my friends thought it was pretty funny. I put it up on my Instagram account. My buddy Danny actually shared it with Lance Armstrong to his Instagram account. We didn't hear back. But I will tell you this. I got the last laugh, so to speak. I participate, and I'll get to more of this later on, but I participate every year in a race called the Leadville 100 mountain bike race. It takes place in Leadville, Colorado. Most of the mountain bike race occurs over 10,000 feet. It's pretty hard. And Lance Armstrong has won it back in the day when he was drinking the juice, literally. And they invited him and all former winners back last year for the 40th anniversary of the Leadville 100. And this guy beat Lance Armstrong. I'm not 100% sure that he was racing, and I don't know if you've seen Lance Arm lately, but he's gotten a little bigger and a little puffier, so he's probably not quite as fast as he used to be. But I put it on my Palmaras. I beat Lance Armstrong, so there we go. I'm a big fan of having a plan, and having cancer was no different. So after naming Lance and understanding a little bit more about what my treatment was going to look like, the first being a surgery including a bilateral neck dissection, I decided, even though it was the dead of winter, that I needed to get in better shape. I believe that we heal better, we cope better when we're in a good place mentally and physically. I'm not sure if I was in a great place mentally. I'm still processing the whole cancer thing, but I knew that I could get back, get rid of some of my winter flab. In Colorado, when the snow starts to fall, we like to hit the slopes and probably drink too many beers after hitting the slopes, and that's definitely where I was at the time. So I worked on getting myself back into shape and ready for the first round of my treatment, which was bilateral neck dissection at Swedish Medical in Denver, Colorado. And as you can see, there's a theme starting to slowly evolve, and that's around unicorns. I really have no idea where the whole unicorn thing came from. I actually had a friend call me or emailed me, text me, whatever people do these days, and said, he goes, man, I noticed you've got lots of unicorns all over your Instagram page and on your blog. He's like, are you a brony? Does anybody know what a brony is? I didn't either. A brony is evidently a male that's really into My Little Pony. So, yeah. I unknowingly put myself into a very weird subcategory of people. So, yeah, there you go. The surgery went really, really well. And you can see that I came out of it, actually, that was right after I came out of it, or maybe I was still out of it and in the process of coming out of it. But I had incredible care at Swedish Medical. And a little interesting side note, this would have been February of 2020. There wasn't a lot to do when I was recovering other than laying there. And I remember at one point, because I'd been watching a lot of news, I asked one of my nurses, I was like, hey, I keep seeing this thing about the coronavirus on the news. Are y'all worried about that? No, they give us some updates now and then, but right now they think it's just a couple of isolated incidences in New York and Seattle. Joke's on us, right? Bad joke, but the joke's on us. One of the vows I made to myself, well, first of all, my doctor had to set me straight because I've had a couple of knee surgeries, lots and lots of broken bones. I've had more stitches than I have had fingers. And I was just convinced that after surgery that I would be up and about in no time. And I even mentioned that to my doctor that after the surgery I had already booked a week in Breckenridge, Colorado to go snowboarding. And he was like, no. He's like, Breckenridge, Summit County, that's a great place to have a knee injury. They have lots of orthopedic surgeons up there fixing people who fall on the slopes all the time. But it's not a place where you want to be bleeding out on the side of the mountain. You need to spend 2 weeks minimum on the sofa, bored out of your mind. And I didn't listen to him, but my wife did. So I sat on the sofa for 2 weeks, bored out of my mind. After that, I vowed that I was going to get back on the bike and I was going to ride not only after my surgery, before my radiation, but I was going to ride throughout my radiation treatment as well. And it really became, I've been a cyclist for 30-something years, I would say. And a lot of that was, I got into it for the health benefits because I'd gotten so large that I couldn't run anymore. And it's stuck with me. It's gotten me through a lot of stuff. It's a great place to think. It's a great place to work off energy. It's a great place to get a really awkward tan that stops right here. I think they call it the farmer's tan or the cyclist tan. And cycling became just super important to me in terms of my own health and recovery. What I didn't know at the time was that it was going to become that vehicle where I hoped I could make a difference. Some point, probably somewhere during my radiation treatment or after my surgery, I got sick of answering phone calls and texts and emails about, how are you doing? Tell me what's going on. What can I do? I get it. Everybody reaching out, I'm lucky, right? People wanted to know how I was doing, wanted to know how that I could help. But telling the same story over and over and over again about your diagnosis and about your treatment is taxing and tiring unto itself. So I started blogging. I created an Instagram account, and that's where the Bikes Kill Cancer came from. And I have a good friend who's an artist, local artist in Colorado, and we were talking on the phone one day, and I was like, Danielle, I could really use like a logo for my blog and my Instagram account. And she's like, well, what are you thinking? And I was like, I don't know. I'm calling the blog and the Instagram account Bikes Kill Cancer. So what kills cancer best? And I was like, unicorns, right? And unicorns on bikes are even more powerful. And so Danielle whipped up, not the design that you saw, but the first design, which was minus the snake. We feel like we had to have the snake in there to make it really clear that we were killing cancer. Metaphor or something, I guess. So that's when I started blogging about my my journey, so to speak. Whoops, going too fast here. And for a while, that's what it was. It was just a way to keep people sort of informed of what was going on through pictures and words. And my wife was really impressed with how much I was putting out there about how I was doing and feeling. She's like, "You've never been this open with me." And it's like, well, I've never had cancer either. So there's, times are a-changing. 6 weeks, daily radiation treatments, which in hindsight, if you're going to get radiation treatment, do it during a pandemic where everyone's told to stay home, because it makes getting back and forth to the hospital so incredibly easy. I was on first name basis with the valet, and often I would come back out of the hospital. I had given him my keys. He didn't even give me the little slip of paper to identify my car. Come back, hour and a half, 2 hours after the treatment, and he would have moved my car 10 feet. There was not a lot going on in terms of, well, there was a lot going on, but in terms of hospital traffic, the pandemic really made radiation a little bit easier on me. So I finished my radiation treatment, and then I quit. Not life, just my job. I tried to return to work, and over this surgery, and recovery, and then radiation, and then more recovery, I went back to work, and we were still in this sort of weird partial lockdown where only so many people could come into the REI store at a time, and I just couldn't take it. I just, sick of people yelling at me, telling me how much they needed a Patagonia jacket, and they didn't understand that I was keeping them from doing that, and I was violating their rights, and I couldn't take it. So I'm very fortunate. REI was incredible. I kind of sort of told them what I was thinking about doing, and so they helped me work out an exit plan, which allowed me to do things like take all my vacation, keep my medical benefits for a bit longer, and it really allowed me a little bit of time to sort of stop and think about what was going on in my life. Because even though I quit, and I remember the day my wife and I had come back from a camping trip, went upstairs after being grubby for a couple of days in the woods, and I showered and came back down, and I looked at her. I said, "I think I'm gonna go to work tomorrow and quit." And she's like, "Great, what's the plan?" I was like, "Absolutely no plan other than I'm gonna quit." Again, REI was incredible, but it wasn't where I needed to be at this point in my life. I figured, and now at age 51, I hopefully have, that sort of feels like the halfway point. Hopefully that's the halfway point of my life. 100, 102 sounds like a good stopping point. And so I started really thinking a little bit more about what I wanted to do. I didn't really come up with anything other than I like to ride my bike. And write, and put pictures up on Instagram and blog about it. And as I was getting a little bit more into just sort of posting more about my treatment and learning more actually about the HPV vaccination, because I remember when the doctor told me that, "Oh, your cancer is caused by HPV." I was like, "I thought you said I had head and neck cancer, not cervical cancer." That was the scope of my knowledge. I knew that it caused cervical cancer. I sort of took a little bit of a deeper dive and realized that the HPV vaccination really needed some help, right? I mean, it needed some good publicity. It needed a boost to get the word out there. And I had friends start to reach out, or someone reached out to me about my Instagram account, and they're like, "Hey, we saw your logo. We would love to buy some of those stickers from you." I was like, "I don't have any stickers." So I messaged him back, "Sure, no problem. How many do you want?" And I think they said like 5, and I was like, $10. And then they're like, great, here's my address. So I immediately got online and ordered a batch of stickers. And I was like, what? I've just ordered 200 stickers. I probably should figure out a way to pay for them. So I put up on Instagram, stickers for sale. All money will go to Sarah Cannon Cancer Institute, which is where I did my treatment. Went to bed. Woke up the next morning, opened up my Instagram account and looked at the messages, and I was like, well, crap, I need to order some more stickers. So I ordered some more stickers, and I don't remember the exact, it wasn't a huge amount of money, but I think it was like $400 or $500 that we ended up raising for Sarah Cannon. And this kind of got me to thinking. I was like, oh, maybe I could do some more of this stuff. I've got a lot of free time on my hand. I've quit my job. There's a pandemic going on. And it's weird how you put things out in the universe, because a couple of days later, I got a phone call or text message from a friend of mine out in Seattle who social media, we'd stayed in touch, but hadn't really talked in a while. And he's like, hey, have you heard of the Fred Hutch Cancer Center? And I was like, sort of. He's like, well, they do this, this big bike ride every year. And of course, because of the pandemic, they're going to do a virtual ride. And I'm like, well, what's a virtual ride? He's like, oh, well, you just sort of choose your own adventure. You can ride inside on your bike, or if you want to map something out in your neighborhood. I was like, that's a great idea. I'm going to ride to the top of Mount Evans from my house. Anybody know about Mount Evans? One of the two 14ers, so it's like 14,000 and some change. In Colorado, there's 50-something 14ers in Colorado. I'm just state bragging now. Y'all are so flat here. I got here, I was like, oh my God, there's so much oxygen in this state. But I was starting to feel better. I'd been riding and exercising throughout the treatment, and I was really sort of getting back into the swing of things. At this point, we're late July. The thing with Mount Evans is they keep the road to the top closed to vehicles for a good portion of the summer until they get all the snow and stuff out of the way. So we had the mountain to ourselves, literally. It was closed to vehicle traffic, so only hikers and bikers. And so I decided to do my Fred Hutch virtual ride from my house to the top of Mount Evans and back, which is about 108 miles. And I enlisted a group of friends that you can see there, and we spent the day riding to the top of Mount Evans and back, and raised over $5,000 for the Fred Hutch Cancer Center. I was like, well, that's pretty cool. I was like, what else can I do that's really dumb? And again, you put things out into the universe, and somebody out there got the message that, like, hey, there's a guy that's willing to do dumb things. And I got an email from a young lady at Immunize Colorado, and just was looking for ways to partner, to sort of get my story out there, talk about the vaccine. And I was like, well, I was thinking about going down to Durango, which is in southwest Colorado, and riding the Colorado Trail back to my house, which literally ends about 10 miles from my house, so about 500 and something miles on the mountain bike. I was full of confidence and swagger. I just ridden to the top of Mount Evans and back. I was like, this is going to be a breeze. It's basically just, riding bikes all day and camping and hanging out with friends. What I didn't take into account was that the back of my throat was still raw and unhealed from the radiation treatment. And when you're burning, 5,000 to 7,000 calories a day, riding, or in my case, often pushing your bike uphill through the Rocky Mountains, you quickly realize that it's really hard to eat enough food to sustain the energy that you need to keep going. And after 4 days, I had to pull the plug. I'd already lost about 10 pounds in that course of time. I just could not physically get the food down. It hurt, and there really wasn't enough water on the trail. I mentioned the peanut butter and jelly sandwiches. Try eating like granola bars all day without enough water to chase it down. So truly a misadventure, but I've got a lot of great video and a lot of great footage out of that, and some great stories. And it also just sort of illustrates how important friendship is in your life, because I not only had a couple of great friends who chose to accompany me, and then were very understanding when I was like, yeah, I know we said like 10 days out here, but like 3 days is kind of my limit. Y'all ready to go home? And they're like, we get it. How are we getting home? I was like, I'll call Guillermo. He'll come get us. And he did. So lesson learned, but still a great time. So as I mentioned, these fundraising things, they just sort of started feeding on themselves. And the picture to the right is myself and my wife. We did a live Facebook broadcast when we did a big raffle when we were doing the fundraising for the Fred Hutch fundraiser. That's the original sticker down there. So very similar to what you saw earlier, but just without the evil snake in there as well. Now, I've mentioned her a couple of times, and I'm probably going to get emotional again here. But I guess I would probably still be here if I didn't have a wonderful wife. But my wonderful wife, Ashley, helped me get here with a lot more grace. And she was an amazing person to have by my side. So I just wanted to make sure that you saw her beautiful face as well. We just celebrated 19 years on May 27th. Been together for 23 years, and just like what I wrote in the card to her for our anniversary is, I was like, I think this is working out. So I want to sort of switch gears here a little bit, and you're like, Jay, you're supposed to be talking about HPV and vaccinations, not smoking. But I want to start with talking a little bit about smoking as an example of what good science and what persistence can do in moving the needle in the right direction. I haven't been here for the whole conference, but I've been to these immunization conferences before, and I know that there's often a lot of frustration from the participants. There's sometimes maybe even a bit of, will we ever get there? But I think there's a couple of examples that we can look at that show that science, good science, that persistence, and good people can make a difference. If we look back to the 1960s, about 45% of the adult population was a smoker. Now, I was born in 1969, and if you're of that age or maybe a little bit older, you probably remember when every single house had not one, not two, not three, 4, 5, 6 ashtrays, unless you were lucky enough to grow up with parents who didn't smoke. You went to the restaurants, there was always an ashtray in the center of the table. If you flew on a plane and you turned and looked to the back of the plane, you could see that, well, you couldn't actually see the people in the smoking section because it was just a blue haze. It was like Woodstock or like a Grateful Dead concert back there. It was so smoky. But guess what? Even though Big Tobacco put up millions, if probably not billions of dollars to try to refute good science and put up roadblocks for good people, we're now down to an adult population that's about 11% of that population smokes. Unless you live in Colorado where everybody smokes, though it's probably just not cigarettes. But y'all have it legal here too, don't you? I thought I saw a shop. Yeah, well, y'all know. Y'all are just like Colorado then. All right. This is not a self-portrait of me as a kid, but it's kind of what I felt like as a kid growing up. My dad was a cop, so we always had to wear seatbelts. And I can remember my dad would probably be like, have child services called on him now. But I can remember at some point in my life, I was probably like 12, when you pretty much you're getting close to being 13 where you automatically know everything. I remember telling my dad that I didn't want to wear my seatbelt anymore. None of my friends did, and that it was restrictive, blah, blah, blah. So he swung by in the police cruiser one day, and he was a patrol cop, picked me up and took me down to the police station, and opened up a book full of photos of car wrecks with people who hadn't been wearing seatbelts. So from that day on, I wear my seatbelt. And I share this with you because at one point, I don't remember the date now, I'm blanking up here, but about 80% of the adult population did not wear seatbelts. And say what you want about Ralph Nader, make fun of Ralph Nader, but again, the science and the data showed that wearing a seatbelt could save your life, right? Who doesn't wear their seatbelt? Raise your hand if you don't wear your seatbelt. How's that for public shaming, right? Point made, okay. And if you were thinking about raising your hand, now you're probably thinking like, well, maybe everybody else is right. Maybe I should wear my seatbelt. So I share those two incidences in history that good science and good people can make a difference. Now you're gonna have to really bear with me on this one. First of all, that's my dog, Michael Scott. World's sweetest Great Dane. But what I really want to point to you in the back is that amazing structure. Because I think this amazing structure, or at least the people that built that amazing structure, represent us. And in February, we had in Colorado one of those fake springs for like a week. It was in the 70s. The little bit of snow that we had in town had melted. You can see the creek is starting to fill up from snow runoff. And people were coming out, clearing brush from their house, and a lot of it just gets thrown along the greenway, and the county comes by and picks it up later. Well, this group of young girls, probably elementary school age, decided that they were going to build a fort. And I watched this play out over a couple of days as I would walk Michael Scott along the greenway. Further down from their fort was a group of boys of about the same age. And now this could be taken as girls versus boys, but that's not my point. It was a group of small boys trying to build their own fort. Now these young ladies, whether they knew it or not, applied some basic engineering and physics principles to stack this wood and lean it against each other. You can't see it, but they even put a little bridge across the creek to make it easier to get across, to haul the sticks and whatnot over there. Focus, teamwork, using sound physics and engineering principles. While just down the way, further down the greenway, these young boys, I don't even know what they were doing. I was embarrassed to call myself being a male with them. They were, well, there was one kid, every time I go by there, he was literally just digging a hole. Digging a hole. And then the other two boys were not using sound engineering principles. They're like just were sort of throwing things like willy-nilly, pretty much just making it up as they go along, kind of like those anti-vaxxer folks, right? They're like, oh, I'm just going to pull that out of there over here. I'm going to use this over here. I'm literally just going to build a house of cards and hope that it stands upright. We are those young girls. We know that the science that we're quoting, that we're sharing with people is the good stuff. We, you, all of us can make a difference as a team. I know that at times it probably feels like when you're having that conversation with that person who just doesn't want to get it through their skull, it's frustrating, right? But know that there's a bunch of you out there and that you're all working and moving in the right direction. And we'll get there. We may go backwards a little bit, but we're going to get there. So I appreciate all the work that you do. Your community appreciates all the work that you do. I real quickly just want to wrap up with what I'm doing now, other than jet setting across the country, giving this speech. I mentioned that I do the Leadville 100 mountain bike race every year. This will be my 4th year. I've finished every year. It's a goal unto itself to go under 12 hours. You get a big belt buckle. I'm shooting for under 9 because then they give you like a Texas-sized platter belt buckle. But I do it for a purpose, not just for the belt buckles. I raise money for a local nonprofit in Colorado called First Descents. They have a national reach working with young adults who are fighting serious life-threatening illnesses and especially cancer, and get them out doing life-changing outdoor adventures in beautiful Colorado. Well, yeah, that's really what I'm doing is I just ride my bike and try to raise money. But I would ask, I could really use your support. No, I'm not asking for money. I'm just asking you to follow the QR link Check out my Instagram account if you'd like. If you're an Instagram person, I'd love to have you follow me. I also brought a stack of stickers. If you'd like to help me spread the word, I'd be happy to give you one of those stickers. I have worked with several different pediatric offices in Colorado who have bought stacks of these to use them as sort of a gateway tool. That sounds awful. Gateway tool, gateway sticker to talk to children and their parents about the importance of vaccines. So if you're interested in something like that as well, you can always just reach out via Instagram, and I'd love to connect with you. And also, just like when I'm out doing crazy bike adventures, I have a bunch of great partners. The Golden Mills, a local beer hall in Colorado. One of their owners is a cancer survivor, and they help me kick off my fundraising every year. And then Ove Negra is a local pack company that helps me carry all my gear when I'm on my bike. And then Infinite Nutrition, I mentioned it's really hard for me to eat. So I have to consume most of my calories in liquid form when I'm on the bike because it's really hard to swallow a Cliff Bar with no spit in your mouth. And then Quiggs & Rado is my wonderful graphic designer that makes all my cool logos and stuff for me. So thank y'all so much for being here. I really appreciate it.
Jay, we'll open for questions for a minute. We'll take a few questions if that's okay. Yeah. Does anyone have any particular questions for Jay at the moment? I do. I don't know if anyone? Ivan, any questions on Zoom? Okay. I'll go ahead and ask then.
Sure.
I'm curious as to how long it took for your doctor to kind of make a connection to HPV, and did that happen up front? Did that happen at some later point?
So to the actual HPV, that came out during, I'm trying to remember, during one of the early, or during the phase of diagnosis, so the PET scan and a lot of blood work. There's these different markers that they look for. Please don't ask me any more medical questions.
That's
it's
okay.
going to look really dumb up here.
No, not at all.
But yeah, it came out
Fairly early.
Yeah, well, and so when I had the bilateral neck dissection, they already knew that there was a good chance that there was cancer in my lymph nodes. So when they took out the lymph nodes, they were actually sending them to the lab while I was still under, as well as I had, I don't remember the name of it, but during the same surgery, I had some cancer in the back of my throat. So they were cutting out margins and taking that to the lab as well. So.
Got it. Thank you. Yeah. Anyway, yep. Question?
The radiation treatment that you had, and I saw the mask. My brother had the same type of mask from when he had radiation. Was that proton treatment that you had?
I'm sorry, was it what?
Proton?
Was it?
What
No,
was
it
it,
was.
proton? Yeah,
It was radiation.
radiation. They hadn't built the mask?
Yeah, so they took that. They take a mold of your face and build that mask because they literally bolt you down to the table so that you can't move. It's kind of amazing the advances that they've made in treatment of head and neck cancer. So I have people in my support group who had cancer 10, 15, 20 years ago, and they literally just blasted their entire head with radiation, and they're dealing with the fallout of that now with a lot of dental issues, sometimes bone reconstruction as their jaws or parts of their skull deteriorate. Mine was very, very pinpointed, which hence why I had to have the mask. And one of the hardest things I had to do was keep my weight up. It was very, very hard to eat with the sores and stuff in the back of my throat. For a while, I'm not a fast food person, but I was on first name basis with Ronald McDonald for many, many weeks because the only thing that tasted good and the only thing I could keep down were vanilla shakes and Cokes. So I was getting probably about 2,000 calories a day from McDonald's. Like, yay, go fast food. So it has its time and its place, right? When you have angry, hangry kids who you don't want to go home and cook for, McDonald's rules. When you're getting head and neck radiation treatment, McDonald's rules. So rest of the time, stay away from it.
From one cancer survivor to another, God bless you.
Yeah, well, I'm happy that we're both here. Thank you so much.
Any other questions for Jay at the moment?
Yeah.
Janish?
Since HPV is transmittable, was your wife tested?
She was. Sorry, I'm trying to remember. Yeah, I mean, she was, and I thought that they may recommend, and she asked her doctor, should I get the HPV vaccination? If you probably figured out, I'm not a medical doctor. My understanding is now there are some adults all the way up to age 40 that would still be a good candidate for the HPV vaccination. My wife, at the time, I'm going to tell you my wife's age. She's going to be so bad. So she would have been 41 at the time. So I guess her doctor decided that she was sort of past the point of no return. So, yeah.
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 Thank you.
Yeah.
Is there one more? Okay, there's one more coming, Jen.
Hi, I'm
Hey.
Iris Cooney from Horizon NJ Health. Thanks for sharing your story. I'm curious if you also saw dental providers before your diagnosis, because I have a dental background, and we tend to do an oral cancer screening, like internal and external. So I'm curious if you did see like other types of medical providers that can have or could have likely picked up on a referral for further analysis before your diagnosis.
Yeah, so that's a great question. So I'd been seeing the same dentist for, at that time, probably 7 or 8 years, and they had never done any type of oral examination. What was really cool, though, was my head and neck surgeon, Dr. Nemechek, actually called my dentist, explained to him what was going on, because he wanted me to get in there and get basically like a mouth guard piece made, and that's how I administer my fluoride treatments to myself. So I actually started the fluoride treatments before surgery, before radiation, to, I guess, make my teeth as strong as possible and to keep them as strong as possible. My dentist now, after talking with Dr. Nemechek, they do dental screenings with all their patients now, and they have caught one well, I don't say caught, but they have found what they believe might have been, they referred someone to a doctor because they were concerned about some sores that they saw in their mouth that seemed persistent and wouldn't go away. So, yeah, yeah. I'd say if your dentist isn't doing the oral screening, ask them why. Yeah.
So one, I would like a sticker. So that's my number one question. Number two, what is like the best way for us to support your organization and like your events moving forward and bringing awareness and,
Sure.
and things like that?
So clarify, Bites Kill Cancer is not an organization. It's a one-person pony show. It's me. I thought about at one point sort of, like, do I want to start a nonprofit? But what I realized is that there are already some incredible nonprofits out there in the cancer community doing incredible work. So what I'd look to do is just to continue to support them. The one that I've really latched onto has been First to Sense. You can probably tell by looking at me, I'm not a young adult. I didn't qualify for any of their programs because I had aged out. But the way I look at it is I think about when I was a young adult, where you feel like you've got the whole world in front of you. I just can't imagine if I had been 25 and gotten this diagnosis. I think at age 50, I had so fortunate to have a great job. I had incredible medical benefits. I feel like I got off pretty darn easy. I just can't imagine being that young adult having to go through what I went through or any other type of cancer treatment. So that's really where I put a lot of my focus now. And then when these opportunities arrive, I love to just come out and share my story and try not to cry in front of a bunch of strangers. So it always gets me. I'm like, man, I've got this. And then as soon as I start, I get all emotional. So, I'm sorry. Can I do something real quick? Yeah, my wife will be so pissed at me if I don't take a selfie, because she's like, did you get pictures? And I'm like, how am I supposed to take pictures of myself while I'm speaking?
Do you want them to smile or stand up, or what do you want them to do?
I don't know. Let's see.
You doing a 0.5 up there? Somebody give a wave.
That's good enough. I think everybody had their eyes closed. Appreciate it.
Thank you. Any last question? Oh, we have one last question, and then we'll wrap up.
Yeah, so just more of a comment. So my name is Kim Daly. I'm a region medical director with Merck Vaccine. So first of all, just thank you so much for sharing your story. We've had a lot of conversations today about HPV, which are so important, but it's always, to hear from the voice of the patient. So thank you. Just a couple of clarifying points. Just a reminder, the vaccine is 9 to 45. Head and neck cancer is now the most common type of HPV cancer. So it's not just about women and cervical cancer. Men are the most likely person to be diagnosed with an HPV cancer, and as Jay shared, there's no screening, right? So by the time even a dentist finds it, you have invasive cancer. So, again, I just wanted to put that plug out. This is like, I often say, if you're human, you need to be vaccinated. It doesn't matter how you identify. We all have mouths. Not all of us have a cervix, but there are 5 or 6 different kinds of cancers the vaccine can protect you against. So if you are human and you are taking care of humans, 85% of humans are going to get HPV. It's not a question of if, it's a question of when. So if we know that, we want to make sure we protect those patients, and vaccination is our best approach. So thank you again, Jay, for sharing your story. And if anyone has any questions, I'm happy. I'm not trying to steal the thunder, because you're the star of the show. So thank you.
You're the medical expert, though, so thank you.
Jay, one question did come in via Zoom, so I do just want, there was one last question, because we're Zooming this as well. Do you get routinely tested for HPV? That's what...
I do not, but I do get a yearly PET scan to ensure that my cancer has not come back. And I don't know, maybe you can answer that. Is like, I don't know why they don't continue to test me. I don't know if I'm immune now, like I'm a super user, or...
It's a complicated answer.
All right.
What I would say is we don't know if people clear the infection or if it goes dormant. And so there's a lot of discussion about that. Again, selfish plug for the vaccine. It protects you against 9 different kinds of HPV. So even though Jay has had, maybe one type that caused his cancer, there's still benefit even for those patients. I'm going to think of women who've had cervical pap smears that show they have HPV. We still want to protect them against those other kinds. It's kind of like if you ever had the flu, right? You still get your annual flu shots because you want to get protected against the kinds of flu that you haven't had. So to answer your question, we don't know if you completely clear the infection. You probably do through treatment, right? Obviously the radiation, and I'm a breast cancer survivor, so I'm with you on that page. But what I would just say is, again, there's 9 different types in the vaccine. It is Gardasil 9, so still benefit to protecting your patients even if they have tested positive. You want to protect them against those kinds they've not yet acquired.
Hey, thank y'all so much. I'll hang around if you want a sticker, so.
Hang out for a minute. Can you hang for a minute?
Thank you so much.
My pleasure. Thank you. Can you hang for
Oh, yeah.
People want stickers? Okay, awesome. All right. All right. Oh, they're handing him already. Okay, so folks, first off, don't go running, but we do want to thank you all tremendously for joining us today. We are delighted to be able to provide this program. We want to give a shout out and a thank you to our partners at the Department of Health. Thank you so much once again for trusting us to co-sponsor this program. Kendra, thank you again for your leadership on making the program happen. A reminder, your evaluation is the QR code on the back of your program brochure. So we encourage you to just sit tight for a few minutes and go ahead and complete the evaluation. That is also important so that we can provide you the credits that you need. Lastly, I do just want to make one final comment. Thanks. I just want to remind you all that today more than ever, you are not only public health professionals, right? You are also public citizens. And if you have concerns about things that are happening and decisions that are being made, whether it's locally in your community, at the state level, at the federal level, please don't forget to use your voices, right? You are public health, yes, but you are also residents of this state and of this country. So please use your voices to say what you need to say, communicate with your legislators. It really is incumbent on all of you and all of us as experts in public health and as members of the country. So please be sure you use your voice. And if you didn't vote today, make sure you go do that. Thank you all for coming. Zoom folks, thank you for participating. We hope it was valuable for you being in this remote process. Kendra, if that's all we need? Oh, got it. They need to sign it? Got it. And folks, if you are a nurse or a health educator, be sure you signed that sign-in sheet on the separate table, right? Just make sure you did that if you didn't already. Safe driving. You can use that door. It's okay. Mwah. Take care. Have a great day, everyone. Take care, Ruth. Good to see you. Good to see you.